तारा भाई
पहला लेक्चर।
अरे वो PUJO पे कौन बैठा है? लेक्चर कांटे ने डाला है ना। वो करना।
सर मुझे होस्ट बना दीजिए। या राकेश डन डन।
Good evening, Dr. Takvani. Dr. Saswat, you are answering?
Good evening, sir. Yes, sir.
Who else is answering?
Sir, I am answering. I'm Dr. Miraj, sir. Good evening, sir.
Okay, good evening. Good evening, Dr. Gite.
Good evening, sir.
Dr. Takvani has already joined.
Yes, sir. So we will wait for 2-3 minutes and start.
Yeah, we'll just wait for 2-3 minutes. Yeah. Good evening, Dr. Takvani.
Yeah, good evening, sir.
Sir, good evening, sir. Takwan, sir.
Good evening. Good evening, Gaurang.
Dr. Gite
Good
is
evening,
there.
Dr. Gite. You can start. I joined. I could join. I joined actually, but I was
No, I saw
connected.
that you had
But
joined
now
quite
I'm
early.
audible. Am I audible?
Yeah. Yes,
Yeah,
yes,
yeah.
you are audible.
Okay. Thank you.
Right. So as I told you, we have got about 5-6 cases. We will see how many we can finish. So the first case will be the routine case where we'll have the total explanation, question answers, and total coverage of the topic. And then we will have different case scenarios where you can discuss about mainly the management, because the history part is already over. So mainly the investigations, and in different cases, what are the important aspects of investigations and history that you can teach the students. Maheshwari has joined?
दिख नहीं रहे, sir.
No. So at present, there are 2 students who are answering, Dr. Takvani. One is Shashwat and second is Dr. Miraj.
Okay. Okay.
And Dr. Paras is just going to narrate the history, and he will just show investigations as per their request.
Okay. Okay. Go ahead.
Okay, so 1 minute and then we will start. Okay.
Okay. No
Paras,
problem.
after 1 minute, you can start.
So first, history or history is over.
No. We'll start with the history.
Okay. Perfect. Perfect. No issues.
So Dr. Paras will just give a short history. So Dr. Paras will just start with a short history.
Yes.
And we will ask the other students about, what are the important questions they want to ask to complete the history. And then you
Perfect.
can add your comment to that.
Perfect. Perfect.
सर
Yes, start करते हैं.
ज्ञानेंद्र शर्मा सर ज्वाइन हो गए, उनको को होस्ट बना दो.
Yeah. 1 second. Huh? Make him, yeah. Last time Dr. Gyanendra Sharma had presented, Dr. Takvani, he had presented 8 different scenarios.
Right.
And at the end, he had taught the students almost everything about PU junction.
Okay.
So,
Okay.
it was a fantastic
Well done.
presentation by him. So we
And
are
they,
so lucky to
today
have
they should be able to perform today.
Yeah, so I am so happy and lucky. The students are lucky that 2 of you are there.
No. I have learned a lot from the Gyanendra. So it will be for me also.
Yeah. I
Sir,
think,
sir.
Dr. Gite, we should start now.
Sir, this is the 4th session. So last year we have taught to the different people, and these are the different people.
Correct. Fine.
So we'll start.
Yeah, Paras, you can go ahead.
So scenario first is with a history of pain in right flank on and off since 3 months, fever since 3 days, nausea and vomiting since 3 days.
Okay. So, Shashwat, this is the history, the basic history. Now, what are the important questions? First of all, what is the differential diagnosis that comes to your mind when he's a 24 years old, right, boy, having a pain in the right flank and has got nausea and vomiting since 3 days
Sir,
and a fever?
most probable diagnosis, sir, would be a stone disease. It could be a renal calculus or a PUJ calculus or a ureteric calculus. And then, sir, it could be pyelonephritis, and it could be, sir, PUJ obstruction with secondary UTI, and it could be a cystic disease of the kidney with acute change. And
Saswat, what was the nature of pain?
sir, it is an on and off kind of pain, but we would like to ask more questions regarding the flank pain, sir.
Yeah.
Okay,
Was
so
it
you complete the
severe pain,
history.
or pain was prior to the fever, or fever and pain together? It's a fever after 3 days. Okay, since 3 days only. Okay, fine.
Yes,
Fine. Sorry.
sir. For
Okay.
pain, we would like to ask the site, the onset, the severity, the duration and progression of the pain, and the nature of the pain. Then the diurnal variation, any periodicity in the pain, aggravating and relieving factors, and associated symptoms.
Right.
Associated symptoms like?
Sir, it could be, sir, like fever and nausea, vomiting are given. Then it could be sweating and, sir, palpitation also, if it is a severe pain. And associated, we must also ask any history of lithuria or pyuria and hematuria if it is present, sir. And along with that, sir, we'd also like to know any lower urinary tract symptoms if the patient is having any dysuria, if he's having.
Shashwat,
Yes, sir.
you should not carry it down with the today's presentation in the exam. This is a 24-year-old male with pain.
Yes,
So when you are sitting in your own OPD, so first thing come to your mind is pain and fever, means some there should be somewhere obstruction by something.
yes, sir.
Yeah, infection. Either it is obstruction with or without infection.
Yes, sir.
This is the bottom line behind that symptomatology. So the obstruction. So at the age of 24, what it could be? The first, it could be a stone disease.
Stone disease. Yes, sir.
What it could be? Second, it could be some cystic disease, congenital, simple, complex with infection. Third, huge obstruction.
Yes, sir.
Fourth,
Sir, could be a benign tumor also, sir.
Why benign tumor will produce fever?
Sir, if unlikely, but sir, if there is any history of trivial trauma or superadded infection is there, sir.
Okay, so it could be a renal trauma also. So you ask the negative history, whatever you are thinking as a differential diagnosis. So for example, stone disease. So stone related, last time also I told you, stone related 3 to 4 points,
Yes,
you
sir.
should be, there should be ready in your mind. These are the things I am going to ask to rule out the stone disease, so that the examiner will know you are asking about the stone disease.
Yes, sir. Sir, lithuria and hematuria, lower urinary tract symptoms, any dysuria, any history of strangury if the patient is having.
Okay, so Dr. Takvani, you can just give your guidance.
No, it's okay. Let's move from here.
Yeah, okay. Fine. Paras, go ahead. Paras,
So, history of present illness was given by patient himself and seems to be reliable. According to him, he was asymptomatic 3 months back when he started having pain in the right flank. Sudden onset, progressive, dull aching in nature, released on medication. Pain has increased since last 3 days and is associated with vomiting. Patient also complains of fever with chills since 3 days, which was relieved by medication.
go ahead.
History of nausea, vomiting, burning, micturition, urethral instrumentation or surgery in past, dysuria, trauma, facial puffiness, fetal edema, breathlessness, jaundice, headache, backache, bleeding disorder, blood transfusion or anticoagulant test. Patient have no comorbidities or no surgical history in past. Patient is mixed by diet, no allergy to any food or drug. Sleep is normal and undisturbed. Bowel, bladder habits are normal. No addiction to any form of tobacco or alcohol intake. Family history is nothing wanted.
So is there any mistake in the negative history? Can you go back?
No.
You said that no history of fever, nausea, vomiting.
That he wanted to say past. Just
Past, okay, past negative history. Okay, fine.
Yeah.
Go ahead.
Anything else we should add? What about he is only 22 years old. So during pregnancy, whether there was any history? Dr. Shashwat?
Sir, actually, PUJO obstruction is a bit.
No, because your one of the differential diagnosis was PU junction obstruction in this case.
Yes, sir. We can inquire if he has access to his antenatal. Somebody can correlate with the antenatal history, or any scan was done for the mother, or any childhood, any previously during till this age, whether any ultrasound or any scanning was done.
Okay. Dr. Takvani, what do you think? What
I'm trying to figure it out because I had some problem with the connectivity. She is 30-year female, if I'm not making mistake. Swaswat.
He is a 22 years old.
22-year-old male, sir.
Okay, okay. And she was all right till this has happened. Right?
Yes, sir.
In the past, no positive history is there.
No, sir.
Is that right?
Yes, sir.
Okay. So you summarize exactly, means if you have completed the history. Then.
Yes, sir. Sir, 22-year-old male came with right flank pain for the past 3 months, on and off, progressive in nature, dull aching. And for the past 3 days, he's having fever with nausea and vomiting and exacerbation of pain. No other relevant positive negative history or any in the case, sir.
What are your differential diagnosis based on the clinical history?
Sir, my differential diagnosis would be most likely it could be a stone disease, then along with the superadded pyelonephritis, or it could be developing pyonephrosis also. And it could be a cystic disease with acute change. And then it could be a PUJO obstruction, sir.
So first is the stone,
Yes,
either
sir.
in the pelvis or ureter, obstructing
sir.
and leading
Yes,
to
sir.
infection.
Yes, sir.
Second,
Sir, sir, it could be a, because sir, PUJO obstruction is more common.
why not? It can be a simple pyelonephritis.
Yes, sir, it can be simple pyelonephritis, sir.
Okay. And third, you are suspecting uretropelvic junction obstruction with infection.
Yes, sir. Yes, sir.
Okay.
And lastly, sir, any cystic disease with acute change and UTI.
You can ask Gyanendra. Gyanendra,
Yeah, Anil, good evening.
yeah, good evening.
I think what you mentioned is perfectly right. Stone disease with infection or plain simple pyelonephritis. I would not put anything beyond this in DD unless he gives any significant history in the past or in childhood. That's it. As an examiner, if somebody tells me I am suspecting PUJ, then I know that he knows the case.
Yes, sir.
Agree. Rather, you will prefer to ask for the investigations related to your first two diagnoses.
Yes, sir.
Okay. He is right, I think, to predict right now PGO state in the differential diagnosis should be avoided. Is that Gyanendra you want to say? No?
No, I didn't get you, Anil.
Right. Fine. I think good advice from Dr. Gyanendra. You all agree? Saswat, you agree or you have some
Yes, sir.
argument?
Yes, sir.
In
Completely.
favor your third diagnosis, are you having a sufficient argument to the examiner that why you are suspecting uretropelvic junction obstruction with infection at this particular age?
Sir, it is extremely unlikely, but if asked whether it could be a possible differential, then we can keep it lower down the order, sir.
That way, Shashwat, it can become so many things.
Yes, sir.
At 24, somebody can have a malignancy also. He can have a cyst also. It could be a non-urological cause also.
Yes, sir.
Isn't it? Because
Yes,
we as urologists will know, patient doesn't know, his disease doesn't know that he is coming to a urologist. He only knows he has got a right-sided loin pain. And it could be due to n number of reasons.
Yes, sir.
So from a urological point of view, these two things, and if he says it's a typical loin pain, only 2 DD for me. And then investigation would clear up the things.
Yes, sir.
Okay.
Okay. Yes. So, Miraj, now next what? This is a general examination. You want to see something in general examination in particular?
General examination, I want to see pallor, then koilonychia, clubbing, and I want to see if there is any edema, if there is any facial puffiness, if there is any lymphadenopathy, and yes, the blood pressure of the patient, and the presence of the saturation levels and other, and yes, sir.
Okay, fine. Paras, go ahead.
So general examination, everything was normal.
So in systemic examination, Miraj?
Paras, sir, can I interrupt?
Yeah, please.
Paras, if you say everything was normal, I would not take it straight away. Respiratory rate of 20 is unusual for a 24-year-old fellow. Diastolic of 90 is again unusual for a 24-year-old fellow. But these are things you would expect when he is having good degree of pain and fever. So somebody can point this out, but that is not the primary objective of our discussion. So when you see respiratory rate of 20, it's not normal.
Agree.
What is the upper limit of respiratory rate in the Q SOFA scoring, Shashwat?
Sir, 16.
16. Are you sure?
Sir, I'll have to look it up, sir.
I think it is 22. Yeah. Go ahead. Go ahead.
Yeah, Paras, go ahead. So Miraj, in local examination, what you will like to examine in particular?
Local per abdomen. I want to see if any swelling of the abdomen is there, any asymmetry is there. Then I want to look at on inspection. On palpation, I want to see if any mass is there, and if there is any tenderness. And I want to look for any suprapubic fullness that is present, and then upper. And I want to see the external meatus, the how it is, and yes.
So you should answer the question as per the complaints of the patient. What is the complaints in your patient?
It's pain, fever, blank pain, fever.
So the first possibility you are suspecting is stone disease.
Yes, sir.
Both. So stone may be in the kidney, stone may be in the ureter, stone may be in the VUJ.
Yes.
So it on the our second diagnosis is any congenital obstruction. So in palpable kidneys, tenderness in the loin, fullness in the loin, that should be the probable positive. You may get that type of the positive findings.
Yes, sir.
Okay. Why you told there is a suprapubic fullness? So what you are expecting? What will cause the suprapubic fullness?
Any obstruction in the bladder outlet or in the urethra or
Okay. So how that bladder outlet obstruction will cause pain on one side?
if
So better to keep it simple. Okay. So possibly if it is a congenital or acquired obstruction, the kidneys you may find palpable kidneys, you may find tenderness in the loin, you may find fullness in the loin. So these are the pertaining findings with your case. इसमें से कुछ ना कुछ तो मिल सकता है या नहीं भी मिलेगा. So examiner, if you are asking what you can see on palpation or per abdominal exam, so these are the possibilities, and rest generally you can see a number of things, and scaphoid abdomen, fullness abdomen, any scar mark, dilated veins, so जो भी चीज है वो सब बता सकते हैं, लेकिन this case related these are 2-3 findings.
Yeah. Ganesh, you wanted to add something?
No, sir. No. That's okay.
So, okay, Paras, go ahead.
Yeah. Keep this right. Yeah.
So on inspection, abdomen is flat, central and inverted. No visible lump, peristalsis, involved vein or stomach. All quadrant move equally with respiration. No renal angle fullness noted on either side. On palpation, no local rise of temperature, no hepatomegaly or splenomegaly. A lump is palpable in the lumbar region, extended to the umbilical and right iliac fossa, about 20 into 15 centimeter, soft to firm in consistency, non-compressible or reducible, bimanually palpable, right renal angle tenderness is present.
Can you differentiate it from the liver
Yes,
at this juncture?
yes, sir.
What do
Finger
you think?
inclination is possible between the lump and the costa.
Okay. Now, why it is not palatable if you are suspecting it is renal mass then?
It's a very large mass.
Very
Oh,
large. Okay, okay, fine, perfect. So now at the end of this examination, what you are suspecting? What is your now differential diagnosis?
Sir, it could be, sir, pyonephrosis, sir.
Can it be stone now? Your first diagnosis was stone. Can it be because of stone?
No, sir.
why?
It's a gross hydronephrotic kidney cannot be there with the acute obstruction, right?
Yes, sir.
There can be a chronic obstruction, but then also pyelonephritis cannot give rise to such a big kidney.
Yes, sir. It could be a pyonephrosis, sir.
So what is your now first diagnosis?
Sir, it is a infected obstructed system, most likely pyonephrosis, sir.
Could it be perinephric abscess?
Shashwat,
Sir, perinephric,
yeah, answer.
Patient had stone, one episode
Yes,
of pain, perinephric urinoma, which has got infected with abscess.
yes, sir, could be likely, sir.
What will the palpatory findings if it is a perinephric sort of abscess, acute recently developed abscess? What are your palpatory findings?
Sir, there will be a local rise in temperature. There could be edema over the skin. There could be marks of the sheets or the clothes on the skin. Then
Can there be some problem with the flexing the hip?
yes, sir. The hip will be naturally resting in a flex position, sir, because
There can be, right? So
yes, sir.
palpatory findings plus some additional findings
Yes,
can
sir.
give some hint about the differentiating from the what Gyanendra has said, big perinephric abscess can be there, right?
Yes, sir.
From the hydronephrotic kidney.
Yes, sir.
Okay.
Paras,
Genitalia,
Go ahead.
genitalia uncircumcised.
Go ahead.
so now, Shashwat, this is the history. You have seen the findings. You have come to some conclusion. Now what do you want to do?
Sir, I'd like to order a few investigations, sir. I'd like to request blood workup, sir, including CBC and renal function test and blood sugar levels, along with urine routine and microscopy, sir, and an X-ray KUB and an ultrasound abdomen and pelvis, sir.
Patient has a history of fever. You don't want to do urine culture and sensitivity?
Yes, sir. As per the urine routine microscopy findings, sir, we'll request a culture also.
And second thing is you don't want, means you are able to palpate the mass. You want to do sonography or you directly want to go for a CT scan?
Sir, we can do a preliminary sonography, sir. We can see the status of the dilatation of the pelvic calyceal system, any perirenal collections, and the status of the contralateral kidney. And that can give us some indication or whether it's a solitary kidney. And then we can go ahead for CT scan, sir.
Shashwat, what you will do routinely at your hospital? Tell that only.
Sir,
Don't tell theory. If this patient come to OPD, local tenderness, fever, vomiting, pain, I will admit the patient. I will
yes, sir.
withdraw the blood for investigation. I will start the antibiotic. Send
Yes,
the
sir.
urine culture, urine routine, and
Yes,
bedside ultrasound.
Yes, sir.
यही करते हैं ना, इससे अलग कुछ
जी
करना
सर,
है
नहीं जी सर,
ये और यही एग्जाम में बताना है.
जी sir.
Okay, fine. Bharat, go ahead. So just before that, Dr. Sharma and Dr. Takvani.
Yes.
So in exam, they should routinely say when such a patient comes, they should talk about sonography, or if someone says directly CT scan, it is acceptable.
I think sonography in our circumstances is very much easily available. It can give us some basic details. Based on that, we can definitely finally see what kind of a CT scan we have to advise. For example, this is a very poorly functioning kidney. Now, to document that, we have to take a delayed kind of a plates, or we have to do maybe a conventional IVP, so it can give some idea. If we are doing CT scan, we have to see again for some functional study, because CT scan cannot be having a very delayed CT scan plates. So if we do sonography, we get some specific idea about whether it is kidney only involved. Kidney, if it is involved, then what is the condition of cortex? What is the condition of pelvic calysis system? Any perinephric collection, opposite kidney? So I'm in that way agree with the Saswat, because this is what I practice as Dr. Gite said, that what I practice in my clinic is that I go first for the sonography to have some basic minimum ideas. Gyanendra, you can add or subtract something.
No, this is the answer I want Sashwat and other students to give in exam. Exactly what you are saying, they say that is what is required, because the examiner may ask them that why not only CT scan? Ultimately, you are going to do CT scan. So they have to justify their answer by saying this. So please, Dr. Takvani has given you a very beautiful answer. This is the way you should answer in your exam. Paras, go ahead. Show.
So urine routine microscopy, specific gravity is 1.01, pH is acidic, protein sugar absent, RBC is 6 to 8 per high power field, WBC are more than 100 per high power field, epithelial cell and crystals are absent. On culture, there is no growth. Blood investigation, hemoglobin is 10, TLC is 6200, uric acid is 4.18, sodium is 134, potassium is 4.3, creatinine is 1.33, blood urea nitrogen is 6.31, PT-INR is 1.1, ALP is 48, serum calcium is 9.6 total.
Sonography.
So your total count is normal.
Normal.
Okay. And polymorph, can you go back?
72%.
Polymorphs are 72. Okay, fine.
So on sonography, we don't have the images. It shows right gross hydronephrosis with PUJO narrowing with floating internal echos, suggestive of pyonephrosis with paper thin parenchyma. On left kidney is compensatory in last 13 into 6 centimeter and position, shape and position without any stone in the pelvic calyceal system, and shows mild increase in cortical echogenicity with normal CMP. So these are the CT cells.
Wait. So Saswat, this is the sonography.
Yes sir.
Saswat, routinely you don't get sonography pictures, or in this particular patient you have not sonography pictures?
Sir,
This
usually we get, so in our center, sir, we are doing sonography when the patient presents in the OPD. We have
on your own.
Yes sir, we are doing.
Now suppose this is okay, fine, but suppose it is a small kid, say for example 6 months, right? You
Yes,
people
sir.
must be doing sonography, but do you send this patient to the sonologist, or no, you only do sonography before you take further decisions?
Sir, if it is a clear-cut case, sir, like paper thin parenchyma is there and grossly dilated system is there, we are doing the sonography by ourselves.
So I'm telling you, suppose you have a 6-month child with
Yes, sir.
history of antenatal hydronephrosis, and
Yes,
now
sir.
it has come to you for postnatal advice, right? In that
Yes, sir.
case, you have done a sonography.
Yes, sir.
You take pictures, or you send the to the sonologist and insist to give you certain kind of pictures. Because with the permission of Dr. Gite and Dr. Shah, I would like to show a couple of, and also permission of Gyanendra, because a master of sonography is sitting there. But I would like to show a couple of slides and then we will discuss. But later on, once they permit me, right? So what I request and insist that to make habit to get the pictures of the sonography. So you also see if you have done yourself, that's perfect, right?
Yes, sir.
But suppose somebody is doing for you, then insist to give you pictures. And because if you will read the pictures, you will get idea that what you are seeing and what you are missing, right?
Yes, sir.
Anyway,
Shashwat,
Yes, sir.
as far as the exam is concerned, if I am at your place and if, as what Takvani sir is asking, I will judge like that and I will answer like that.
Yes, sir.
We at our center doing a screening sonography by ourselves and getting confirmation with radiologist with film from radiologist.
Yes, sir.
So एग्जामिनर क्या पूछ रहा है उसका दिल को रीड करना है.
जी सर.
सर आप दिखा सकते सर तकवानी सर.
Yes, sir. But you want me to finish this case or no? I
Yeah,
go.
yeah, finish this case and then we'll go ahead.
हाँ केस फिनिश करके दिखा सकते सर.
ठीक है, ठीक. Go ahead, Saswat.
Yes.
So what are the things you see on sonography, baseline sonography? This diagnosis they have given a PUJ. So
Yes, sir.
suppose this is it is a PUJ now.
Yes, sir.
As per the sonography. So what are the things you see or ask to the radiologist in sonography findings?
Sir, for this particular case, a 22-year-old male, firstly, I'd like to see the normal contralateral kidney in sonography, sir. Then for the affected kidney, sir, we'd like to know the parenchymal thickness, if possible, on all the poles, the upper, mid, and the lower pole. Then the status of the pelvic calyceal system, the dilatation of the major and minor calyces, and whether the pelvis is extrarenal or intrarenal, that we can come to know, sir. Whether
So do you know the normal parenchymal thickness of adult kidney?
Sir, it should be more than 15 millimeters, sir.
And how much the cortex and how much medulla is there?
Sir, cortex should be more than, cortical thickness should be more than 7 millimeters, sir, measured from the.
What about the children less than 2 years?
Sir,
we'll come to that. If you are knowing it is plus point.
I'm not able to recall, sir, but.
Okay, no problem. We'll discuss that. Now,
Yes,
what you was aiming after seeing the sonography, Saswat, what you was aiming as a treatment? Don't go to CT scan. You have done the sonography. You are in my center. What you are aiming in this patient as a treatment?
Sir, actually, on the basis of history, I was suspecting it, and the examination, I was suspecting that patient would be having pyonephrosis. But the blood investigations and the ultrasonography picture shows an indolent case. It's not.
It's a grossly hydronephrotic kidney with paper-thin parenchyma,
yes, sir.
right?
And few internally goes.
Now, what actually based on this, what you are aiming, what could be the likely your treatment from this?
Sir, now I'd like to obtain anatomical CTI view, sir.
The anatomical information generally you enough get in the sonography. You have got now opposite kidney which appears normal. This creatinine is normal. This kidney is paper thin, is grossly hydronephrotic. All calyces are dilated. According to you, pelvis is also dilated. So what further anatomical information? You are not seeing any stone there. You are not seeing hydroureter, right? Your bladder is normal. So what anatomical information you are missing here before you decide little bit about your treatment?
Sir, I want to know the excretion of the contrast, whether it is seen by this unit or not, whether it is present or not. Then any stone we might have missed, or we can also come to know, sir.
Now, suppose even there is a stone, for example, there is a 6 millimeter stone in the ureter which you have missed. But what you are aiming, you will for 6 millimeter stone, what you will do in this particular situation?
Sir, if the hydroureter is traceable up to the stone, then we like to decompress the system initially.
Okay.
And
So whatever pathology, now, for example, you are still missing some idea about the causative factor, right?
Yes, sir.
But you have
Yes,
a
sir.
roughly about gross hydronephrotic kidney. And right now you have said that you would like to decompress. Now, what is the ideal decompression in this patient?
Sir, an ideal decompression in this patient would be a percutaneous nephrostomy, sir.
PCN, percutaneous nephrostomy.
Yes, sir.
Right, I agree. Now, what the purpose it will serve?
Sir, it will have a good drainage and the pyonephrosis can also be drained if there are any.
So if there is an infection, it will get drained. It will drain the urine. It will
Yes,
give
sir.
you further output idea.
Yes, sir.
You can quantitative and qualitative studies you can do, right?
Yes, sir.
And
Yes,
patient becomes symptom free also.
Yes, sir.
Right. Now, whether you would like to see, anyway, I'm agree with the CT scan, for example. Now, would you like to do CT scan after the enough decompression or just prior to the decompression? Now, my question is very pinpoint, is that prior to decompression, if you do CT scan or and above the sonography findings,
Yes, sir.
what else, what specific thing you will get which will change your treatment of decompression with the PCN?
Sir, if we are able to see contrast which is being excreted and it is coming down.
Are you expecting contrast in CT scan when the contrast will appear in such a paper thin kidney? How long you will send the patient in a CT scan center to take the late cuts? Gyanendra?
Boss, I wouldn't do a CT scan.
Gyanendra, CT, suppose if you do CT before decompression or after decompression, enough of decompression?
Anil, I think you and Dr. Gite are leading the children in the NS students in the right direction. You answer what you are practicing. Patient has come with fever, right loin pain, palpable kidney, which is confirmed on ultrasound to be a markedly hydronephrotic kidney with internal echoes. Straight away, start the antibiotics and drain the kidney. That is the priority. Everything else comes later, according to me. And I think you are also pointing in the same direction.
Because you are, see, by adding the CT at this juncture is not going to change your first treatment.
Yes, sir.
Right. And another thing is that you are aiming some functional aspect also in the CT scan, not only anatomical. Now, in presence of such a severe obstruction, you won't get any kind of a idea about the function. Now, if you do after this any of the anatomical with functional or functional study after the enough of decompression, right, you get fair idea about the recovery of the kidney.
Shashwat.
Yes, sir.
Gross hydronephrotic paperithin cortex, adult patient, compensatory hypertrophy on opposite side. So what all, and PUJ, diagnosis of PUJ in sonography.
Yes, sir.
So in this patient, what will be the function on right, that hydronephrotic side?
Sir, I did not get the question.
4 points. So can you judge a function with ultrasonography only? Adult patient, PUJ diagnosis, parenchymal thinning or paperithin cortex, and compensatory hypertrophy on opposite side. So the function of this hydronephrotic kidney is taken by the opposite side.
Yes, sir.
And the cortex is already gone.
Yes, sir.
So indirectly it suggests that this kidney is either a poor functioning or non-functioning.
Non-functioning. Yes,
okay.
Sir.
And internal echoes. There are no internal echoes. TLC normal, local tenderness, history of fever, pus cells 500 per high power field in urine routine. So it is open pyonephrosis.
Yes, sir.
So that PUJ probably draining partially.
Yes, sir.
So without internal echoes, PCN or DJ, it is a matter of question.
Yes, sir.
Okay, so if you told PCN, it can be also accepted. If you tell DJ in this patient also, it can be also accepted.
Agree. I agree with Dr. Gite. This is a nice case to discuss about the internal decompression, whether by the DJ or PCN. And as he rightly said, both can be argued in favor and against. So only thing is that you should remain vigilant for that. Means you should remain prepared for that. If you say stenting, if it is your personal choice or your institutional choice, you defend it, right? And if you do PCN, you should do this. This is a very common debatable issues. Even if you look at the FRCS program, they debate this too many times, and you should know both the sides. That's perfect.
Agreed, sir. Only
Yeah.
you have to depend. It is either infected hydronephrosis or pyonephrosis. These
Yes,
are
sir.
two different things. Whenever
sir.
there are no internal liquors or parenchymal destruction, then it will be only infected hydronephrosis with loss of the parenchyma.
Yes, sir.
So, Shashwat, now the thing is, there are two important things we have to understand to all the students. Routinely, what we do is when we get such a case, we go ahead after sonography. The next thing is we do the CT scan. After the CT scan, we see the function and we do DTPS scan. Okay, this is the routine and that is in your mind. And that is
Yes,
what we are doing. But as Dr. Takvani and Dr. all of them, they have told you that in such a case, what is most important thing is to drain the kidney.
Yes, sir.
And as Dr. Gite has very clearly, justified that when you will do PCN and when you can do, see in all the cases, PCN is the best answer. But if you are doing DJ stenting, in which cases you will do and how you will justify. You understood?
Yes, sir.
So this is what routinely people are doing. But what you should answer in exam, that is what Dr. Takvani and Dr. Gyanendra has taught you.
Yes.
Gaurang, the reason
Yeah.
is that without decompressing this kidney, if you do CT, you are knowing that CT will not so much function.
No,
And
that is what I'm
anatomical
telling.
findings are not going to change much. And if you do
Exactly.
renal scan at this juncture without decompression, you won't get much also idea in the about the functionality of this kidney. So all these investigations will just add on the information that opposite kidney is well functioning and this kidney is not functioning, and you just go ahead and knock down, right? But if you want some effective answer for that, then better to decompress it first and then go for the
Yeah.
additional
So that,
investigation.
no, Dr. Takvani, that is what I'm telling.
Yeah,
that,
I agree. You
that
are summing up and I am
what
just
you are
adding.
teaching them is a perfect, that is what they should answer.
Yeah.
And this is the only, but what routinely people will do, is that is what they get in their idea. If they do sonography, it is a hydronephrotic kidney, go ahead, do CT scan, do so that is what
Agree.
people are practicing, but that doesn't mean that is a absolutely right thing.
Now,
Yes.
why we learn Saswat this way? When we were doing our urology residency, we were not having a CT scan in our own setup. CT scan
Yes.
was a big job. You have to arrange the date, you have to manage the finances of that patient, poor patient, then you have to go with them and get it done. So our initial response for your case was definitely, and that was right also, it as per the even literature and the books, that first you decompress the kidney. So we were used to do decompression. We were just sitting on this kidney, sending patient with a PCN or stent home, and then again getting the patient back and then do again sonography and then decide the further investigations. It was like that.
Yes, sir.
Fine.
Fine.
So you have a CT scan in front of you. What additional information you have in compared to the sonography? Saswat.
Yes, sir.
Ashfat or Najma, either of you can answer.
Yes. What additional findings you have in compared to the sonography?
Sir,
Let us show all the films, huh?
So it is a dilated pelvis, which was
Yes,
there in
sir.
the sonography. Dilated calyceal system, it was there in the sonography. Cortex is very much thinned out, which was
Yes,
there in the sonography. Right? As expected, there is no function, though we have to do functional study. So
Yes,
this
sir.
is what I wanted to convey, that in these particular circumstances, the CT scan has not added anything. And here you cannot say that this is non-functioning kidney just based on the one CT cut.
Yes, sir.
Right? you can say definitely that opposite kidney is well functioning, right?
Yes, sir.
Okay, fine. So, Dr. Sultana, actually, you are not adding here, right? Anything by doing the CT scan in this juncture. Fine. So you have done thereafter. Okay, CT scan report. Yeah, fine. Go ahead.
So the CT scan report shows an enlarged right kidney with gross hydronephrosis with a size of about 17.5 centimeters. There is practically no excretion of contrast seen in the right kidney on delayed scan taken after 1 hour. No evidence of focal lesion or calculi seen. Perinephric fat space appears normal. Right ureter also normal in caliber and course. There is no intrinsic lesion or calculi.
Fine.
Paras does wait less than and ask the question investigation.
No, fine. We discussed the CT. What
Okay.
next you have done? Paras,
Paras,
what scan is this?
Sir, it's a diuretic renogram with
What
the
radioisotope used?
with Lasix washout, sir.
Nee, what radioisotope used?
Sir, I'm not able to.
Anyway, what you will order?
Sir, we'll order a DTPA renogram, sir, with Lasix washout.
Why DTPA?
Sir, it's an adult patient, sir. So we are ordering, sir, DTPA because the radiation exposure.
No,
is,
DTPA. Why? What is the problem with the? If availability is there, what is the problem with the MEC3 or not available MEC3? Then what is the problem with EC?
Sir, MAC3 actually is better because in obstruction to find out the relative.
Now, suppose do you have a MEC3 available in Mumbai anywhere?
Sir, actually, I'm in Dhule, sir. So we are sending patients
no,
to.
I think it is available in Jaslok. In
Okay.
Jaslok, it is available.
So if you have a MEC3, if not available MEC3, then EC, right?
Yes.
Now these two are my choice for the hydronephrosis evaluation over the DTPA, right?
Yes, sir. Yes,
Why
sir.
it is so? Can you tell me?
Sir, MAC3 is actually MAC3 is bound to the plasma protein, so it is secreted by tubular secretion, sir. So in obstructed kidney, sir, it is better to evaluate the differential renal function, sir, as compared to DTPA, sir.
No, but DTPA also give you differential. But what's the problem with the DTPA given differential function in compared to EC is just like a MEC3. We not
Yes,
go
sir.
in the detail of its name, but the properties are almost same. Now, what are the difference between these two property? Very quickly, see, we will not go much on the nuclear
Sir,
physics.
DTPA is by the glomerular filtration, sir.
But what problem is that DTPA is
sir,
not much protein bound.
Sir, GFR, yes, sir.
MEC3 and EC are very much protein bound.
Yes,
so
sir.
it remains in the intravascular space, right? And it
Yes.
takes only almost one pass from the kidney. 90% of the EC or MEC3 get extracted
Yes, sir.
by tubules, right?
Yes, sir.
This DTPA is not that strongly binded with the protein. So it takes almost 4 to 5 passes to get extracted from the blood by the glomerular filtration. So what
Yes.
happens? When it takes so many pass and it is not strongly bound to the protein, it goes into the extravascular space. It's
Yes,
taken
sir.
away by the surrounding tissues also. So there can be what is the differential function? Tell me first. What is differential function?
Sir, split renal function is calculated. We first choose a region of interest, sir, and then we see the escalating
In how many minutes?
gamma activity. Sir, peak activity is noted. It comes in about 2 to 5 minutes, sir.
2 minutes. If
Yes,
it is
sir.
calculated within the 2 minutes, it gives the
Yes,
right
sir.
idea. And what exactly it is? Where radioisotope has reached by this time? 2 minutes.
Sir, it has reached the renal cortex, sir.
So tubules, it is secreted by that time.
Yes, sir.
Tubules, right? Now
Yes, sir.
see in a agent which are extracted by the tubules, right? And are highly protein bound, it will be taken up, 90% will be extracted, right? So there won't be much of the background activity. It won't give you false differential renal function, right? Because
Yes,
your region of interest will be well placed and there won't be much blood background activity. And third, last thing is the sharp images. If you look
Yes,
at the, I will show you, if the time permits, I will show you a couple of images that this is the DTP and this is EC, this is DTP and this is MEC3, right?
Okay, sir.
So you can see this. Now, tell me one of the better means, suppose if I'm talking about the obstruction, one time there is a good indication for DTPA. Which is that indication even in an obstructed hydronephrotic kidney? What is difference between the DTPA gives two things, differential
Yes, sir.
function and
The GFR, sir.
GFR, which is not given by the EC or MEC3.
Yes, sir. They will give the
Right.
renal blood flow,
So
sir.
when you want to know something about the GFR,
Yes, sir.
right, then DTP is the answer. But rest otherwise, in routine investigations of hydronephrotic kidney, I request you, see, I learned this from Professor S.S. Joshi, right? For a number of years, I was not knowing that my center in the Rajkot will do EC scan for me, right? And I was gone doing DTP, I was posting in Euro Education, Euro Academy. He was always commenting what you are doing. I said, sir, MEC3 is not available. He said that you asked for EC. I said, probably that is not available. Then I called my center. They said, yeah, it is very much available and the same cost. And there is a remarkable difference between the split function idea as well, differential renal function idea as well as sharpness of images. Gyanendra.
Anil, one of the beautiful explanations about why DTPA or why MEC3 or why EC has been given by you. One question which I want to ask, the students are right when they say they want to do a diuretic renogram. But when you know it's an obstructed kidney, for sure this is an obstructed kidney. Nobody can deny it looking at the CT images and ultrasound. Is there any role of giving Lasix in these patients, or one can do it without Lasix also? Academic interest. This question is purely of academic interest.
Yeah, no, absolutely important question. See, it is obstructed kidney severely, and you are not decompressed, and you wanted to do a study, right? Now,
Yes, sir.
Lasix, suppose if you give, when you give Lasix,
Sir,
right? You have a functioning kidney where
Yes, sir.
some leak is there, where you want to see whether it is gone down or not going down, then for the after Lasix, it will go
Yes, sir.
down or not. What you are expecting here, renal function curve, perfusion or renal function curve?
Sir, in this case, not able to, the left kidney is showing prompt uptake and excretion of contrast into the pelvic ileal system and drainage. But the right renal unit is not showing any uptake or concentration or excretion.
So what is
So
the
we
question
may-
of Dr. Gyanendra now? You
Sir,
can
we may-
understand the implication of that question.
Yes, sir. Sir, we may not use diuretic in this particular case because there is no uptake of the
So let Gyanendra give answer. Gyanendra.
Yeah, see, Anil, this happens at most of the centers that they do it as a protocol, that they follow a protocol and they give Lasix. But for me, logically, such a kidney which is obstructed, you have proved obstruction. There is no doubt that the obstruction is not there. If somebody says, I don't want to give Lasix, I'm fine with that. We just want to know what is the differential function. That's it.
And again, Saswat, that's why the reason things comes first here is that suppose if you do decompression and
Yes,
you
sir.
wait for 2 to 3 weeks for some amount of recovery, for example, if you are expecting, right? And at that time, if you do diuretic, sorry, you do the renal scan, I think you are better placed. What do you think? After this much of discussion, what do you think? Are
Definitely,
we
sir.
talking some sensible thing or no?
Yes, sir.
Yeah.
Yes, sir.
Right.
Anil, can I just share a small anecdote?
Sir, go ahead, please.
during my DNB exam at PGI Chandigarh, I had got exactly a similar case. And they had given me a history, and then they had brought this patient. When I said I would put a nephrostomy, they had brought him with a nephrostomy. And they said the daily output was 1.2 to 1.5 liters from that side. And the question that was asked to me was, which is the next best investigation? If you are asked to ask for a single investigation, which is the investigation you will do? And my answer that time was, I would do a nephrostogram and not a renogram, because I said I have already established the function. I only want to know the anatomical detail by doing a nephrostogram. And my examiners were Mahesh Desai sir, and he said, I agree with that. So this is how.
Absolutely. That is the purpose of decompressing. That most of the time you get the idea about the function. And now suppose if you in such a in such type of kidney, even if you block the nephrostomy and you do renal scan, still you won't get much of excretion, right?
Yes.
So in that case, you will be still lacking the not getting much of the idea, right? Now functionality you have proved by this quantitative and qualitative examination, and you do nephrostomogram, you will get a beautiful anatomy, which probably you not got during the CT scan, as the contrast has not entered into the ureter, or anytime you have not seen very clearly the ureter, right?
Yes, sir.
And uretropelvic area also.
Yeah, Anil, there was a question that if there is a DJ or a nephrostomy, how do you interpret a renogram?
Right. I don't do renal scan with the double J stent inside. I don't do. In this kind of a patient, my choice always remains the decompression choice is the PCN, where I am agree for a number of years I was not doing renal scan, and was relying on the quantitative and qualitative reports as well as the nephrostomogram. But since last couple of years, availability of renal scan and documenting the recoverability in this way. So anyway, we are not wrong if we say in exam that I will do after significant time of the decompression, I go ahead with the renal scan. Now with the nephrostomy, you can do renal scan anytime. After 2 to 3 weeks of decompression, you just block the nephrostomy and go ahead with the as usual renogram. But with the DJ stent, I don't think it carries any such significance. Here still there is a possibility. Now the function is recovered, you can get some drainage and you can get some drainage comment. But when the stent is there, you are just trying to see the function and not trying to look for the drainage.
The important thing is, Dr. Takvani, that DTP means a renal scan is important, because how we are going to follow up. Now, every time we are not going to do the nephrostomy and find out how much the output is there. Forget about the Gnanendra's case where it was 1 to 1.2 liter. But if suppose the nephrostomy is draining 400, 500 cc, and then afterwards you want to find out.
Have to do renal scan. I agree, sir.
You know. Right. So in exam, I think the answer should be they will do nephrostogram. That is the first thing they will do.
Nice, sir.
So they will do nephrostomy and they will go ahead and to do a CT. I think in exam, some examiner may not only accept that only nephrostogram if we do, and then we'll go ahead. Some people may like to have, there are different examiners, so they may ask for.
I am agree. Otherwise, also you have to document opposite kidney function. Now, suppose see in this particular patient, what I would have done. I would have done sonography, then PCN, then nephrostomogram, and then if I feel that now I have to take a right decision, definitely after enough of the decompression, renal scan to document the opposite kidney functionality as well as the any recoverability in this. So I'm not disagree with this thing. I would have taken out the CT scan in this particular scenario because I much more rely on the sonography, and sonography gives excellent anatomical information, not first time, then at least second time. And then you have a nephrostomy. You can do still if you are missing some anatomical details, you can just inject little bit of contrast and get the thing under the CM and see. anatomy, and then functional study is a renal scan. This will be my protocol and answer.
Fantastic. So
Nice.
in this case, Dr. Takvani, it's fine. Suppose by chance, if it is not a severe hydronephrosis, if it is showing like, good parenchyma, but there is a hydronephrosis. So in that case, will you recommend a CT scan or still your protocol will be the same?
Sir, at least pediatric age group, for
Okay.
example, up to 15, 16 years of age, right?
Fine.
I request, and today my joining in this meeting, the biggest my achievement, if I can convince that to not to do CT scan for the evaluation of hydronephrosis or hydronephrosis. See, see, it is less likely that you are missing the stone. So don't keep stone in the mind in a pediatric age group. If you have a good sonography, if you have a good X-ray QB at the most, right? You are almost ruling out from the history, from this investigation, right? And then straightway you can do a diuretic scan, right? If the parenchyma is good, there is no need to add here CT scan. At least, definitely, I'm sure I've never regretted my decision. I'm propagating this. And even if you go through any of the literature in a pediatric patients with a postnatal evolution of the hydronephrosis, or in infant, or up to the age of 4 or 5 years, where you are not seeing urolithiasis much, and you are knowing some antenatal history was there, there is no role of CT scan in these particular cases, right? Because
Yeah.
CT it's radiation and doesn't give any information. After that, you are going to do renal scan for functionality. For anatomy, you are doing CT scan, which you can get by all means excellent sonographic images right now in these days, as well as the uh, 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 every ideas. I think Gyanendra is more than agree, because Gyanendra's wife, I think she is a sonologist, and Gyanendra has to agree with me.
Yeah.
So now,
Correct.
Dr. Takvani, now it is very clear. And we also do the same thing in the children. We don't do CT scan. The
Right.
question arises only in the adults. So
Yeah.
in adults also, you will recommend the
No,
same
in
protocol?
adult, the thing is bit different. If the history is bit going in towards the means we are at least I am in a urolithiasis belt, right? So if I have some slightest doubt from the history that I have some stone which was left out and chronically obstructed, patient didn't get infection, and now it has become grossly hydronephrotic kidney, right? So in that case, still it is okay with the plain CT QB at the most, because see, there is no, you can't rely on the CT IVP for functional documentation of that affected kidney.
Fine. So now let us make it, before just going ahead, let us make it very clear to the students that in pediatric age group, it is absolutely, you should not go ahead with the CT scan unless and until it is absolutely indicated. So normally we don't do
Now
only.
coming to that point, Gaurang, sorry
Yeah.
to interrupt you, that there can be some ambiguity. I don't say that every time you get an absolute idea about the, suppose sometime ureter where it is hydroureter, where it is opening, whether it is opening into the bladder neck, in the prostatic urethra, or in the female patients, some ectopic insertions are there. And if you don't get idea and ambiguity is there in a hydronephrotic kidney or hydronephrosis, then in my area or wherever institute I have seen, they even they do CT IVP, they need some kind of a sedation or anesthesia, short anesthesia. Now same thing is with the MRI, but the difference is that you are getting in MRU almost every details without radiation. So in my practice, and what I request, that suppose if you have ambiguity in a place like Mumbai, MRU is available everywhere, MRI, and you can go ahead with that investigations. But the point here is there is a study from the US that in a pediatric age group, the radiation, whatever radiation exposures are there to the child, the 56% radiation exposures are contributed by the CT or CT IUPs or some sort of CT scans. And they are now talking too much about this to reduce this, because gonads are exposed, ovaries are exposed, and this is almost more than 100 X-ray chest or more than that exposures, right? One CT IUP with the delayed study.
So majority centers across the India, as well as all guidelines shows what you are telling. No one is doing a CT scan in pediatrics, sir.
Yeah, no one is. That is true.
So,
And
but
all
what
guidelines,
happened, Dr. Gite?
all guidelines shows that there is no need of CT scan until and otherwise it is really required.
Yes. So, but what happened? What the problem, Dr. Gite, is that whenever I get some case for second comment, we had a Euro education, we have a Euro Academy, we have some other now Facebook places where generally they put a case, whether it comes from the Bangladesh, and that was a case exactly in our national conference, which was
Yeah.
I was to present actually, but I could not go, and it was from the Bangladesh. This antenatally picked up hydroelectronephrosis with query uretrosil, and on second or third day they admitted the patient for CT-IUP. Right?
Yeah,
What
that's absolutely wrong.
was they were going to achieve here? So this is what the practice which we are trying to change as a fair practice into the pediatric age group of patient, that for hydronephrosis or hydroelectronephrosis evaluation, which is picked up antenatally, postnatally when you are doing workup, there is as such really no need of doing CT-IUP. It gives you a lot of comfort, giving you best possible picture. But I tell you, the same comfort you will get with one of your sonologist friend. Suppose Dr. Gite is expert, right? Now, some sonologists also want to be expert, right? So if you pick up that person, he will start doing the pediatric sonography very seriously, and like Dr. Gyanendra's wife, and he will start giving you excellent pictures with all anatomical details, parenchymal details, uh, if possible, some about comment about the medulla, cortex, and everything. So there is no as such need of doing the CT-IUP or CT in the postnatal workup. Please don't mention this even in the exam. Even if they try to show you the CT-IUP, you can say that, sir, there is no need of this investigation. I would have been happy with other investigations. And you can mention those investigations in it is postnatal workup.
Fine. So we have made
Two,
it very
3 points
clear.
that I want to make. One is injection Lasix. So Lasix protocol is used only to differentiate between the grossly hydronephrotic obstructed or unobstructed kidney. If you have some doubt in your mind why there is obstruction, in this particular case there is we don't have any doubt in the obstruction or yes or no. So there is no need of Lasix. If you are placed at the PCN, then doing a nephrostogram only help in giving the anatomy of the kidney and site of obstruction, probably PUJO. So if you have considered that this kidney is already gone, then probably that will suffice. If you think this kidney has some function, then it is better to do a functional assessment. So DTPA we are doing not for the defining the site of obstruction, but for to know the baseline function. Okay, and that baseline function, if it is sufficient to go for a pyeloplasty, then same DTPA can be used for comparing post-operatively. So doing a DTPA in this patient is absolutely okay. Nephrostogram, if you want to assess the function again, then you have to go for concentrating ability of that kidney by doing a specific gravity, sodium potassium level. 1.2 liter, maybe only a water.
Agree. So you have to do a qualitative exams, quantity as well as qualitative examination. And
Yes.
nowadays nobody is doing, and that's why we have to rely. But the only point Dr. Gite was that agree with the renal scan, but renal scan after the sufficient decompression of the kidney. In this
Agree.
particular situation of severe obstruction, you are not going to get any idea about the functionality of this kidney.
Absolutely agreed, sir. After decompression only.
Okay. So now we have made it very clear. Now, what is the finding in this case? RS. Show them DTPA scan result.
So it was done with technetium 99. So early dynamic perfusion images, the perfusion to the left kidney appears to be prompt and normal. The perfusion to the right kidney is significantly reduced. There is increased circulating background tracer activity. In the dynamic cortical images on the right side, the right renal fossa is replaced by a large cold photon deficient area, suggestive of grossly dilated pelvic tracheal system, and the cortex appears to be thinned out. On the renogram, the Right kidney demonstrate a flat pattern with a significantly reduced uptake. In fact, GFR of the left kidney is 66 ml per minute, the right kidney is 12 ml per minute. The split function is 83% on the left side and 16% on the right side.
Do you have a pictures?
Yes.
Show us. Gyanendra, this is a DTPS scan in a grossly hydronephrotic kidney. Do you think this split function is overestimated? Or no, you will believe this in a non-decompressed kidney?
Could be, sir. It could be a false positive reading also, sir.
I think it would be false positive.
So again, we would have become much. This gives us a lesson that in this particular patient, we would have become much happy if this scan done after the sufficient decompression. You agree, Saswat?
Yes, sir.
Right. So even in the this exam is okay, fine. That is very much important. But later on in the practice also, na, if you don't want to waste the resources, it is better to decompress in this particular clinical scenario and sonography findings, and then go ahead with this. Right. Here again, it will be difficult. Now see, you have made the life more difficult with this much of split function. What treatment you will advise?
Very
Sir,
correct.
actually it's on the borderline, sir. Now it is advisable to salvage the kidney, sir. It's not a straightaway indication for nephrectomy, sir.
Again, my question is that if you are you convinced with the nephrectomy or you will saving this kidney?
Sir, we'll have to
In a
decompress
presence
and-
of compensatory sort of hypertrophy on opposite kidney.
Sir, actually, on the basis of split renal function, sir, it's 16%. So I'd like to decompress the system and review a scan after 4 to 6 weeks,
Yes,
sir.
again. So that is what the answer is. That at least now you are saying that I will decompress the kidney. I will repeat this study after 3 weeks, and if I will seeing some improvement, right?
Yes,
Then
sir.
you can decide. Now, see, this is the we have double the resource, right? Spending of the resources, double. So,
Yes.
but still, this is the way I will answer right now in this particular juncture. What you answer, that if the situation is given to me at this juncture, that what is next, then I would definitely say that, sir, I would like to go for a decompression. And after 3-4 weeks, I will do qualitative. If I see only 10 cc or 15-20 cc of 50 cc of urine after 4-5 days, I will still check with the nephrostomogram whether my position is perfect or not. If my position is perfect and the kidney is not pouring the urine, it is pouring the urine but not qualitative urine, right? Then
Yes,
it is
sir.
I can fix up the problem at that level, but I will not take any decision without doing decompression. Gyanendra, you agree?
Yeah, fully
Yes.
agree.
So that is what was done. I think degestanting was done. DTPA scan was repeated. It showed some improvement in the function, and after that, pyeloplasty was done.
Perfect.
So the lesson learned is very simple. Number one, in pediatric group, we never do CT scan. In adult group, when such a case comes, severe hydronephrosis, it is better to decompress and then do the investigation and decide the line of treatment. Everything is clear to Saswat and all other students?
Yes, sir.
Fine, very good. And now you know when to do EC scan, when to do MACP, and when to do DTPS scan. It's very clearly explained to all of you.
Yes, sir.
Fine. Okay. So Dr. Takvani, shall we go ahead with the second case, or in between you want to show your slides?
Excellent discussion. I will go through my slides very quickly. It will be a little bit of revision what we have almost discussed. So I will not take much time, right? If you permit, I share my screen.
Yeah,
Yes,
please.
please go ahead.
So this is what actually recently I presented at the Montreal. So maybe there will be logo of Montreal conference, but anyway. So we all know right? It is very common, 1 to 3%. This is about the antenatal and postnatal approach, right?
Can you make a full screen, Takwani ji?
I have made full screen, not there?
No, it is not coming full screen.
No.
और PowerPoint पे डाल दीजिए सर, presentation में.
First, I try to share again. Oh, I done some mistake. Can you see them or PowerPoint or no?
Someone has asked about the reflux. See, whenever there is a reflux, it is not going to be such a hydronephrosis and not an obstructed system. So we are not going to do PCN. PCN is done only in an obstructed system. Dr. Takwani, if you want, you can just leave and again join. Oh, okay, good. Dr. Takwani, can we just go ahead with the second case? It will be a short case.
Sir, there is a comment now from one of the participants.
Yeah, you can go ahead, please go ahead.
There was a comment from one of the participants in the chat box
Hmm.
that should we do a nephrostomy in all cases of PUJ and then do a diuretic renogram? No.
No.
It is the nephrostomy is indicated to deobstruct a system, especially when there is presence of infection. If it's a clear-cut PUJ which is non-infected, you can very well evaluate it in a standard way by anatomical evaluation by sonography and then a diuretic renogram in a child. And then go ahead with the findings of the renogram. I think, Anil, if you are able to
Absolutely correct answer. The answer is that, sir, it is a matter of sense that sonography picture is there, which is showing paper thin kidney, some internal echoes, patient is having a fever. So I am suspecting infected hydronephrosis with the poor function. In that case, I would like to drain the urine, infected urine, as well as I would like to get idea about, I will decompress the kidney, and later on, I will be assessing much better the renal function, right? Functionality of the kidney. So this is the answer. But it is not true for each and every hydronephrotic kidney, right? So it is based on the given scenario. If you have a parenchymal thickness of around 7-8 millimeter, right, and the PCC pelvis dilatation is around 30 millimeter, and central and peripheral callus dilatation, no symptoms are there, right? There is no need of doing decompression, right? So don't try to make it as a rule. You have to go by case to case.
Why confusion in that person who is asking the question mind maybe because the gross hydronephrotic kidney to after decompression the message gone was by doing the decompression the basic real function will come out by DTP. So they are thinking all gross hydronephrotic kidney should be decompressed.
No,
The explanation what you have given is exactly right. Because if there is a gross hydronephrosis and there is no any indication for decompression, then what will happen at the max? If you have done a DTP, there will be a added background activity, and that is the drawback of DTP where you have to use the EC scan.
Yeah.
Just
See,
for the
Paras,
sake of
can you
discussion,
just go ahead with the screen?
can a DMSS can be asked for in such cases, which will eliminate the background activity of a DTPA and give us an exact idea about the function? Of course, I am talking about non-infected cases.
Sir, differential function, if you want to assess the exact differential function, best investigation still is a DMSA. But if you want to assess the glomerular filtration rate, then the best way is to do a DTP or EC.
Yes,
Okay.
agreed, sir.
Paras, show the second case now.
So the second scenario, the history and examination is just given in brief. A 2-month-old boy presented with a swelling in the right flank region since birth, which is progressive, no aggravating or relieving factor. On examination, swelling is present in the right lumbar region extending to the umbilicus, about 7 to 4 centimeter approx in size, well-defined margins, cystic, soft in consistency, non-tender, non-reducible, non-compressible, moving with respiration. Renal angle fullness is noted. Swelling is bimanually palpable and is dull on percussion. The blood and the urine workup were normal. And
So,
this was
Shashwat, in this case, what is the important history you will ask for?
Sir, we'll ask for any antenatal scans if the mother has had any antenatal scans, and the history of fever, recurrent episodes of fever in the past 2 months, and whether any antibiotics were prescribed in these 2 months, and whether the lump was.
So, what you are expecting in antenatal ultrasonography?
Sir, in antenatal sonography, if there is some hydronephrosis, the AP diameter of the renal pelvis is given, calculated, or if there was any oligohydramnios if in the mother, then that is an indicator of PUJO obstruction, antenatal hydronephrosis. And we can also have an idea about the severity or the prognosis of the hydronephrosis. At what age, gestational age, was this hydronephrosis detected, and the status of the kidneys.
So, Miraj, what are the different ways to find out? Are there any classifications?
There is an SAQ classification, a RAD classification, and yes, sir. And
Shashwat, can you elaborate?
Sir, there are 3 classification systems for prenatal urinary tract dilatation. First is the antero-posterior renal pelvic diameter. It is measured in the transverse plane and at the level of the renal hilar vessels. So accordingly, sir, we can classify whether it is mild, moderate, or severe. And then we have the SFU grading of the hydronephrosis, in which grade 0 is no dilatation, grade 1 is sinus splitting, grade 2 is dilatation of the pelvis and the major calyces, grade 3 is dilatation of the minor calyces as well, and grade 4 is parenchymal thinning. And then the third classification we have is the urinary tract dilatation grading system, which incorporates the AP diameter as well as the SFU grading, as well as the status of the ureter and the bladder. So it also takes into account, sir, the parenchymal appearance, the parenchymal thickness, whether the ureters and the bladder is normal or abnormal, along with the EP diameter, sir. So accordingly, sir, we can classify the fetus prenatally as having a low risk or a high risk antenatal hydronephrosis, in which A1, A1 is before the 3rd trimester, if it is less than 7 mm, and after 3rd trimester, if it is 7 to 10 mm dilatation APD, and then it is considered, sir, low risk. And if High risk is A2 and A3, in which, sir, in the second trimester, it is more than 7 mm with or without central calyceal dilatation. And in the third trimester, sir, it is more than 10 mm of an APD along with the central calyceal dilatation. And for these babies, we need to repeat scan every 4 weeks till birth. Also, we can have an idea about the oligohydramnios, sir.
Fine.
And if the patient, if the baby is a high risk of antenatal hydronephrosis, we can also refer the patient to a higher center for delivery and further management. That way, we can counsel and plan.
Yeah. So, Dr. Takvani, you want to tell them something extra? Dr. Gyanand,
Sir, Shashwat has explained it very well. Now, SFU classification has a lot of shortcomings. So Onen came up with another classification which is called as Onen's classification, which subsequently got modified further as a modified Onen's classification. But by and large, the sonologists across a lot of universities, they felt that measurement of the AP diameter was probably the easiest thing that they could do, along with an evaluation of the ecotexture of the renal parenchyma and evaluation of other factors like calyceal dilatation. And hence the multidisciplinary committee, which consisted of a pediatric urologist, sonologist, and from 8 different universities, they came together and then they formulated this consensus statement, which has now come in the 12th edition of Campbell as a urinary tract dilatation. One significant aspect of this is the use of the word urinary tract dilatation and not hydronephrosis, because somehow it gets imprinted on the minds of every person who reads the word hydronephrosis that it is associated with obstruction. So once we start using the word, it is like using pus cells in urine, and we start thinking that it is always infection. So that is why urinary tract dilatation is a better terminology to use, and Shashwat has explained it really well.
good. So now, Shashwat, this is a case. Now what you'll do? Let us go fast because history taking, investigation, everything has been explained very nicely. So now next, what you will like to do?
Sir, the blood and the urine investigations were normal, and I'd like to request a sonography and then proceed, sir.
So Miraj, when you will ask for a sonography? Immediately after birth? 1 day, 2 days, 5 days, 7 days, 1 month?
After about 48 to 72 hours, because initially there will be a dehydration present.
So it may not show the proper
Hydronephrosis.
Okay. And when you like to do creatinine?
Miraj, even when the examiner has asked this question, you should be very clear. After 48 hours first, because there is oliguria, and after near about week time, because there is a polyuria. So you have to do it 2 times sonography. After 2 days and repeat after near about 4 to 6 weeks or 2 weeks, at least 2 weeks. So the phase of oliguria as well as the phase of polyuria should go. Takvani sir.
Can I say a few words about the timing of the sonography? See,
Yeah,
if
please.
you are suspecting intravesical obstruction, or you have a antenatally detected bilateral hydronephrosis, or you have a solitary kidney with the hydronephrosis, it is better to do it in first 48 hours, 24-48 hours, right? If infravesical obstruction, it is better to do on the same day. But if it is a unilateral hydronephrosis or hydronephrosis, better to wait for 7 to 10 days, because you are not going to lose anything by waiting, but you are, as CS rightly said, you can cover the dehydration phase, so you can have a proper findings rather than having some underreporting, right? So my practice is, if I have a certain indications on antenatal antenatal sonography, then I suggest to get it within 24 to 48 hours before the patient get discharged. means mother gets discharged with the baby. Otherwise, I call the patient after 17 days for first sonography.
Fine. So I think you have explained it very nicely, because here we are, even though it is a PU junction obstruction, you are covering most of the pediatric other causes, and it will be very useful to the students when we are discussing other cases also.
Once they go a little bit, I now I have changed my laptop. I can show you a combo effect of the Anil Takvani and Gyanendra together. Probably because there is some contribution of a couple of slides and the thoughts from the Gyanendra. So it will clarify the many things related to the hydronephrotic workup and specifically postnatal workup. But right now he is going well. So go ahead, please.
Okay, so this is the ultrasonography. Unfortunately, when I asked him about the antenatal sonography, he insisted we didn't get it. He insisted that it was normal, and they did the sonography after birth only because there was some swelling seen in the right side.
Perfect.
So
perfect.
we don't have antenatal ultrasonography and no other finding. So this is a finding. I think it is not very clearly seen. Can you just read out?
Still okay, Saswat.
Yes,
Saswat, you can just talk
Saswat,
about
tell
this.
us how you will see for the enteroposterior diameter of the renal pelvis in a hydronephrotic patient.
This is done on the second post.
Yeah.
This is done on second day of birth.
No, it's fine. You have done on second day or fifth day, right? Now,
Yes,
where
sir.
exactly how you will do the measurement of the renal pelvis?
Sir, we look at the transverse plane measurement, and that is taken at the level of the hilar vessels. And
Okay.
we
So
measure
do you think
between
are
the
you
renal
seeing?
cord-
Are you able to see any transverse plane here, or these are longitudinal and sagittal?
Yes, sir.
Any? Can you show me?
Not clearly, sir. I cannot.
I agree. I agree.
Appreciate, sir.
I agree. But you are knowing, your answer is perfect, that you have to see anteroposterior diameter, right?
And
In
we
a
have to
transverse
measure
plane
between the renal
or
cortex.
axial plane at the renal hilum, right? If you should not measure into the extrarenal pelvis, right?
Yes, sir.
Otherwise, it will give you false exaggeration of the finding.
Yes, sir.
Fine. And the rest other things you can get in the longitudinal or sagittal plane, which are known as a sagittal or coronal plane, which are known as a longitudinal planes, right? Other
Yes,
details like cortex, right? Cortical
Yes, sir.
thickness, parenchyma, medulla, medulla and cortex, corticomedullary junction, cortical thickness, cortical appearance, right? Peripheral callus dilatation and central callus dilatation. All these things you can beautifully get into the well done sonography, right?
Yes, sir.
Okay. But your answer is right for AP diameter. Okay.
Yes, Paras, read.
So the right kidney is enlarged with normal shape, position, lipodextrum, measures about 6.5 into 2.7 centimeter with gross hydronephrosis with anteroposterior diameter of pelvis 22 millimeter. Query PUJ optics.
So Miraj, now this is the thing. Is it a complete sonography report? Will you like to have this report, or you will discuss with a sonologist and you will stand there and you will find out what are the findings?
I want to know the calyceal dilatation and the. Yes, sir.
Yeah. So and the thickness. So whatever Dr. Takvani, Dr. Saswat has said, all the 5 important things you like to see. So when you send the child for the ultrasonography, ideally we should be there, even if they are the expert, and we should find out all the findings. So now this is a ultrasonography. Next, what you would like to do?
Next.
This is the ultrasound done over 28 today.
I want to do the blood investigations.
Blood investigations for okay. I think this sonography is much better. Can you just read it?
Yes, sir. Sir, it shows a well-distended grayscale ultrasound of the KU of the abdomen and pelvis, sir. Sir, bladder is well distended and the left kidney appears normal. Corticomedullary differentiation is well maintained. And the right kidney is having gross dilatation of the pelvic calyceal system and the peripheral calyces. And there is parenchymal thinning, which is appreciable. And sir, we cannot know, sir, posterior acoustic shadowing is visible. And on sir, hydroureter is also not able to appreciate, sir. On this given film, sir, cannot comment on hydroureter.
Fine. So now next what?
Sir, this is a
So there
sir,
is no change. There is no change in
Yes, sir.
second day or in this sonography.
Sir, according to the sir guidelines given, it is recommended that we do a voiding cystourethrogram, and along with that, sir, renal scintigraphy, sir.
Okay, so let us have some discussion about the VCUG. I think for exam purpose, your teachers can guide you more. But suppose if you are in consecutive 2 films, 2 sonographies done at the interval of around 3-4 weeks or 6 weeks, then you are not seeing ureteric dilatation, your sonologist to whom you are relying, not seeing ureteric dilatation, right? And patient is not having any episode of sepsis, right? In that case, suppose if you do VCUG, what you are going to achieve, and if you don't do VCUG, what you are going to miss?
Sir, practically in this situation, sir, even if there is vesicular reflux, which is missed on ultrasound, it is going to be very minimal, and it is not going to change the course of management.
So
Sir.
what is your institutional practice? Will you do VCUG or you will skip
sir.
VCUG?
No, sir. We usually skip VCUG. We get a renal scintigraphy, sir.
I absolutely agree, because if you have a reliable sonologist, which you should, the argument should not be in other way. In that case, if you have a 2 or 3 sonographies done in the interval of 2 to 3 by the age of 3 months, and if you are not seeing ureteric dilatation in any of the sonography,
Yes.
doing VCG is absolutely not only invasive investigations, involves a lot of radiations and chances of introducing infections. So lot many things are there which you can definitely skip.
Fine. So Saswat, now it's very clear what you like to do.
Sir, I'd like to obtain an EC scan, sir.
Fine.
Now here what radioisotope you have used?
Sir, it's not mentioned in this plate, sir.
Now the Saswat, here I want to say once again I want to request those who have still joined that in this particular evaluation it is better to do MEG3 or EC scan rather than the DTPA renal scan. The reason are, again I explain you that these are the tubular extract and they extract 90% of the radioisotope in a first pass from the kidney. So chances of background activity as well as the having a sharp images are very high in compared to the DTPA. DTPA takes 4 or 5 passes and it gives a lot of background activity, and because of that it can give sometimes you false reading of the split function as well as not that sharp and clear images, right? So in a hydronephrosis workup, initial workup in these kind of cases, the better radioisotope is MEG3, or in absence of MEG3 is EC scan, right?
Fine.
Anyway, whatever scan you have done is perfectly all right, but this is my
Answer.
practice.
No,
right?
perfect. See, Dr. Takvani, they are going to appear for the exam. And
Yeah.
what are the guidelines? See, here we are showing them what has been done.
Yeah.
And it is very clear that doesn't mean that is the protocol.
Right.
So at the end, once they know it, what should be done, they will answer that. in exam.
Ideal answer in the exam when you are evaluating the suppose there is a history of antenatal hydronephrosis or no history, and postnatally you are evaluating the hydronephrotic kidney, the better radioisotope is MEG3 in absence of MEG3 EC, because these are tubular extract, and I have explained the advantages of that over the DTP.
Fantastic. Correct.
So answer even in the guidelines also this. But now the DTPA is the thing is that the DTPA is done since the very beginning, since many years, and its availability is very much. So it is something like it is almost on the tongue of
Every
everyone that go for a DTPA scan, right? That what exactly was with me in my first. I am 23 years in a single center practice, not having a renal scan facility in my city, and still I have a probably largest collection of these sort of cities with these renal scans. But initial practice, I was not knowing this difference, and I was also subjecting patient for DTPA. But after many instructions from Professor S.S. Joshi, and reading the literature, get convinced that the MEC3, or in absence of MEC3, MEC3 is not only non-availability, but it's costly. EC serves the same purpose like MEC3.
Right. Okay, just read the finding.
So the left kidney showing propped uptake, concentration, excretion and drainage of the MAC3, sir. But the right side, sir, there is delayed uptake and slow concentration, sir. And I think
probably you are not able to see it very clearly.
Down below, the child has voided also, sir.
Yeah.
This also you can suppose if you are in a same center where you are practicing this thing, you can ask your center to give anyone the different color lines, right? So the demarcation is much easier. So that also you can request. See, they are very much most of the time cooperating. That in our discussions and the online discussions, we are not getting much idea about these color combinations which you are giving. So they can modify these things, right?
Okay. So we'll do the next time.
But no way, no problem. Here you have again a poor uptake or poor differential function kidney on affected side, right?
Correct.
Yes,
it is only showing, I think,
Sasha,
differential function is only
very quickly
6%.
tell me that we generally do a diuretic scan, and in a 2-month or 3-month child with such a affected kidney, which are the pitfalls or which are the variables which affects the diuretic curve, and you can't comment about the diuretic curve. Diuretic curve doesn't carry any importance. Which are the variables affect the diuretic scan or diuretic curve?
If it is done very in the neonatal period, then the renal kidney unit, the renal unit is immature, sir. So the tubular secretion may not be apparent, sir.
Second is poor function. For example, here the poor is a poor function. Third,
sir, if it is the hydration of the child is not maintained, the effect of
okay, fine. Fourth,
if it is a massively dilated system, sir, then
there will be reservoir effect.
Yes, sir, there will be reservoir effect.
Very good, excellent. Any more?
Sir, rarely what happens is there is high pressure in the bladder if the child is not able to void or we have not catheterized. So it can give a false positive
So
effect.
over distended bladder or micturition, post-micturition film you might not get.
Yes,
next,
and
one more thing is the erect posture, which is very easy
effect of the gravity.
Grown-up children, but here in this patient. So these are the all variables, and the important which you said is the tubule and glomerular maturation, right? See the GFR. Have you ever come across a study where they said that this diuretic curve, which is more than 20 minutes, less than 10 minutes, and equivocal 10 to 20, are those data are for the adult kidneys or for the neonatal or infantile kidneys? Right?
Sir,
right? So what happens? See, these kidneys are GFR, which is absolutely not matching with the adult GFR. It is only after the 2 years their GFR matches with the adult GFR. So their GFR less, and otherwise whatever you have mentioned, you have excellently mentioned all these variables which can affect the diuretic curve. So diuretic curve is a very poor thing to interpret the neonatal or infantile or up to the 2 years of postnatal hydronephrosis. I think Gyanendra can further elaborate if necessary.
I think Anil, he has mentioned everything and you have elaborated on the same. In exam, it's fine. They will be talking about the renogram curves and the T-half values. But even if in their institutes they are not agreeing to these THAP and drainage curve in infants and children, they can very well justify it, saying because it is the new edition of Campbell even mentions that the THAP values are not indicative of obstruction in children
Yes, sir.
because of the reservoir issue. So I personally never look at the curves and the THAP values in children at all.
Absolutely.
So let's discuss this case, and then Anil, you can go with your presentation also.
No, most of the thing Ganadhar we have discussed. So maybe it will be just a revision. Okay, fine.
Okay, now just show the function and decide what you want to do. Shashwat, can you just read Paras?
So this was a EC scan done with technetium. The percentage contribution of the left kidney was 93.9, with right 61.1%. The EC clearance of left was 139.1 ml per minute, and right side was 9 ml per minute.
Fine. So Shashwat, next
Yes, sir.
what? Or Miraj, you can also answer.
So we can try to decompress and evaluate again for any improvement in the function.
Gaurang sir, Gite sir, and Anil sir. somehow
Shashwat, would you
have a
like to
feeling-
summarize this patient? How much AP diameter, peripheral and central callus dilatation, cortical conditions, as well as split renal function? Would you like to summarize?
Yes, sir. 2-month-old male baby, sir, and having a lump in the right side of the.
So it is
right
palpable
kidney.
kidney,
Yes, sir.
right?
And
Palpable kidney in a suspected UPGO like condition,
yes, sir.
right? What is the answer for treatment?
Sir,
No
this.
sepsis.
Sir, we can. This is a. So split renal function is less than 10%, sir.
Fine,
On the
perfect. Would you still preserve or no? You knock out.
Sir, I'll wait for the child to grow up.
The
And
Sunday,
probably at 1 year.
see, coincidentally Sunday at the SCPGA Lucknow, a girl won the prize. Her title of the presentation was the preserving the kidney in a less than 10% DFR in suspected cases of UPGO.
Sir,
She was from the this King George University, I think. From King
sir,
George.
Campbell says that to be reliably sure whether the outcome of a preservation surgery or a correction procedure, we have to get a DMSA scan.
You have to?
Release a DMSA scan, sir, to reliably
fine.
get
But
the split renal
see,
function.
in such a hydronephrotic kidney otherwise also, I
Yes,
think DMSS will not add much. It will give you a differential function almost in this range only.
Yes, sir.
But in that case, what literature says in a absence of sepsis, what literature says to preserve or not to preserve, and what our teachers' experience says.
Sir, what
Just go, Paras. Just show him that rhinogram. I just want to show something. The uptake. Can you just show the uptake? Just
Anil,
enlarge it.
are you
Just
convinced
enlarge
with this
it. Yeah.
rhinogram and the split renal function?
Then it just show that earlier. Paras.
Yeah. Please.
Yeah, just expand it.
You expand.
Yeah. See, even though everyone means they have said something, still if you go to see on the right hand side, can you see quite a lot of uptake is there in
Yes,
the
sir.
kidney?
Sir, this is exactly why I was trying to ask, are you convinced with the split renal function given by the rhinogram? I don't agree with that.
Because
Agree.
I feel that there is a quite a lot of, means it is not a 6% function.
Yes, sir.
So
what
you
we
have to
can-
take all things
follow-
holistically. And that's why here comes the role of a well-done sonography comes very much, because
Yes, sir.
it will give you cortical thickness. Any cortical thickness which is less than 3 millimeter, right, in an infantile age is considered as a atrophy of the cortex or atrophy of the parenchyma. So cortical thickness, which can be relatively measured very well in a very well done sonography, can give you also insight about your decision making. So here cortical thickness, if that is not very much bad into the kidney, into the sonography, right? And if
Okay.
pelvic diameter is less than 40, you can 40-50 millimeter at the hilum, and you have this much of renal, this uptake into the renal scan, I think all the way this kidney is to be preserved, and it is a palpable mass. Now palpable, how many times you have examined this patient? Have you examined multiple time or one time only?
No, we have examined two times.
Saraswat,
Both the time it was
what
there.
happens? Today it is palpable. After
Yes,
48 hours, if you try to palpate, it is not palpable. How it can be explained?
Sir, it could be a Datel's crisis that
Yes,
there is an intermittent
So
obstruction.
I've seen a couple of cases, even my anesthesiologist daughter, one of the anesthesiologist daughter, he brought the child, the renal kidney was palpable. I was really scared. Oh, it is a grossly hydronephrotic kidney, lot of pelvic dilatation, you have to rush. And 48 hours after, the palpable kidney was absolutely disappeared, lump was disappeared, right? So,
Yes, sir.
but then if you look at the sonography, the hydronephrotic changes are not much regress, right?
Yes, sir.
Maybe some changes, but all those things remains. But the tense kidney, which is really because of Dieter's crisis, right?
Yes, sir.
Yeah.
So, but all the way, if I am at your place, I will go ahead with the pyeloplasty, which is preserving this kidney. Now to again in this patient, whether to do some anatomical more study or not, because where exactly the uretropelvic junction, if you are not comfortable with the sonography, right, then what
Yep.
to do?
Sir, we usually do a cysto RGP, sir, prior to.
Yeah. So this is the only, sometimes suppose if I'm not comfortable anatomically, where exactly I will put the incision, where I will get the uretropelvic junction, whether it is mal rotated little bit of kidney or not, exactly I will be approached anteriorly or not. If I'm having some doubt, still I avoid doing CT scan or anything. Like you can do prior to this little bit of retrograde study, and you get anatomical information. I do that way, but very rarely, but I do. Gyanendra.
Yeah, I think you have explained it very nicely, and that should be done in this case. Fine. Now there is only a short third case, just twist in the tail. Paras, can you show the third case? Then we will see the slides of Dr. Takvani. So Miraj, this patient has got two problems. He has got a dull aching pain on and off since last 6 months in the right flank, and patient has got lower urinary tract symptoms. There is no hematuria, dysuria, lituria, no comorbidities or surgery in past, and there is no significant finding. So now lab findings are almost normal. PSA is also 1.53. So now next what?
I would like to do a CUE and look for an ultrasound findings to find out if any calculus is there and any UTI is there and any for lower urinary tract symptom, any infections, the UTIs and prostate. Yes.
No, there is no infection. There is no fever.
Yes, sir. I want to look for any hematuria in the CUE, and I want to ask a history of trauma. And
No, forget about that. Now we are not going more in details of the history. These are the history. Now this is like a short case. So what next investigation you like to?
ultrasound CUE.
Okay, Paras, just show ultrasonography.
So the ultrasonography shows a moderate hydronephrosis, abrupt cutoff at PUJ with no hydroureter, no calculus. The prostate size is 32 grams with PBR of 33 ml with pre-void of 150.
Next.
Shashwat.
Yes, sir.
So what are the things? patient has got two complaints. Patient has got pain as well as lower urinary tract symptoms.
Yes, sir. Sir, I'd like to get a CT-IU done for.
Okay. So what are the findings? Shashwat, can
Yes,
you
sir.
see?
Yes, sir. Sir, this is a CCT image. Coronal the axial section, sir. They're in the delayed phase, sir. The left side renal unit appears normal, sir, having contrast excretion in the pelvic calyceal system. The left ureter is
Shashwat,
also
can I
visible.
interrupt you? See,
Yes,
I agree with your answer of CT IVP, but what you are suspecting and how exactly you will order this? What you are suspecting?
Sir, the 52-year-old male with the flank pain and lower tract symptoms, sir.
Hey, from the based on sonography, what you are expecting now?
Sir, it could be a PUJO obstruction, sir.
With maybe the etiology responsible for it.
Sir,
at this particular age or even in the adult age, chances of in this kind of a patient, chances of having crossing vessels,
yes, sir.
Are quite high.
Yes, sir.
Right. And now you are doing CT. I am agree with it. But what additionally information you would like to have and you will ask for?
That probably will get a angiography also.
Yeah, angiographic will, right? Means in arterial studies.
Yes, sir.
CT. Okay, fine. What are the findings here?
See it clearly.
Sir, the cortical thickness appears maintained on the right side. There is gross dilatation of the combined intra and external dilatation, and pooling of contrast is also seen in the
Where?
dependent film
Ashwar.
side right.
See it properly.
See all pictures carefully. See fourth column, second row.
Paras, earlier one. Shashwat, can you see the last left-hand side, the last row?
Yes, sir. So extrarenal pelvis dilatation is there, sir.
Where is the dye?
Sir,
Is there
this
any
side-
dye in that dilated system?
Yes, sir.
Or it is in the periphery?
Calculi or
Sir,
Appears.
Shashwat,
Yes, sir.
first CT scan, third column, second row. क्या फोर्थ रो? तो उसके आगे, उसके ऊपर थोड़ा मार्क अभी पहले जहां दिखा रहे थे वहां पे. Yes. Stay there. See that. See that picture carefully.
Yes, sir.
Even the first one, the first row, just see. The third, fourth one. First row, fourth and fifth. Yeah, fourth and fifth. See. Can you see?
Yes, sir.
Understood? So at the periphery, you can see the contrast.
Yes, sir. Periphery, we can see the contrast, sir.
Yeah, but not in the center. Now see. Now what is your diagnosis?
So it looks like a filling.
space.
Sir, it looks like a filling defect, sir.
So to label it as a hydronephrosis, all the dilated calyces should communicate with the pelvis.
Yes, sir.
And if it is on ultrasound, there is a central complex of the dilated pelvis. Or in CT scan, that pelvis should be communicated with all calyces. Or in sonography also. तो वैसा दिख रहा है क्या यहाँ पे?
नहीं, sir.
क्या दिख रहा है बोलो?
And it is not taking any this
Yes, sir.
contrast. This non-enhancing area.
So what is it?
That is where CT scan is better than ultrasound.
Yes, sir.
Yeah. In this patient, definitely agree. right?
It could be, sir, upper tract tumor, sir.
Tumor?
Cyst.
अरे भाई, parapelvic cyst.
Parapelvic cyst, yes, sir.
Then,
Is not communicating with the PCS, sir.
yeah. And that is causing. So that is what I wanted to show you, that in sonography, many a times they will say it is hydron, because they cannot differentiate between both.
Yes.
So they will say it is hydronephrosis,
See.
or dilated pelvis. So only when you do CT scan, you will be.
Yeah.
So
in
now
this
that
kind
is.
of a patient is indicated.
Yeah. So that is one part. Now what else? He has got lower urinary symptom. So what do you like to do?
Sir, I'd like to do a, RGU MCU, sir. A uroflowmetry, sir, initially.
Ask uroflowmetry. Show
Yes, sir.
uroflowmetry. So
Is voided, sir, 340 ml.
Yeah.
340 ml. Qmax is also low, sir. Average flow is also 5, sir. Could be due to a stricture disease, sir. I'd like to obtain a anatomical investigation, sir. RGU MCU.
okay. We have just stopped here. We have not done anything more than this. Okay.
Yes, sir.
So Dr. Takvani and Dr. Sharma, if you can just comment on this, so that students know what to do about. And then if Dr. Takvani is ready, we can see his slides.
Yeah,
Sir,
I'm ready,
This
sir.
is a very good case that you have shown. I had a very similar experience where I was called by another person to assist him in a pyeloplasty in an adult patient who was 25 or 27-year-old. I went there and I said he had done an ultrasound and a renogram, not a CT. So I said I would do an RGP, and the RGP showed that the ureter was absolutely deviated on one side, and there was stretched out calyces. And so we just put in a stent. I said you should get a CT, and the CT had shown a stone in the lower ureter, which was missed on ultrasound.
Okay.
So correlating with the history, when later on I had asked the patient the history, he said he had a sudden onset severe pain for a single episode. Ultrasound done showed gross hydronephrosis, and it was reported as gross hydronephrosis, and immediately renogram was done. And the renogram showed very poor function, because an obstructed kidney with acute obstruction, it had shown a very poor function. And so the diagnosis of PUJ was made. So always correlating the clinical history with the findings is important.
Absolutely.
And
Agree.
all said and done, as Anil has said, a good sonologist will mention it as a dilated extrarenal pelvis, if not a parapelvic cyst, and will mention that the calyces are not dilated. And that is a good enough indication that something is amiss.
Fine. A good lesson to learn.
Yeah.
So now onward, please, I request all the students that even in practice, when you are suspecting PU junction, and that also in a child, please be there when the ultrasonography is taking place. So you know exactly what he is doing and what you want, and you can extract the proper findings. Fine. So Dr. Takvani, you can
Yeah, I
share
will
your
not take
screen.
you stop sharing. I will not take much time. Let us
Yeah.
go through the some. I hope it's very useful to the students. So I'm sharing. I hope this time it is perfectly all right.
Okay, fine.
So all of us know it is one of the most common prenatal USG finding, this hydronephrosis, right? And this is the sentence from the Gyanendra, that the boy be born with the presumptive diagnosis and not the symptom and disease. And that's why our responsibility is very high. Just 10 days before I listened the cough, right? He was invited by his parent institute in nationwide from the Ohio, and he was talking about the observational protocol for the postnatal in a postnatal period. We'll come to that very quickly, right? So these are the all possibility. We are working on tightrope. We have to one side, we don't want to deteriorate on the renal function side. Another side, we don't want to aggressively investigate. One side, we don't want to jump into the operative without proving it. And these are the couple of values which will be useful to the resident. As we all know, two subgroups, parenchyma and collecting system. Parenchyma, again, two parts, cortex and medulla. So this is the cortex and this is the medulla. Here you can see this is a corticomedullary differentiation, right? In a well-done sonography, you can see almost everything. And parenchymal thickness together, it is 7.5, 8 millimeter and 10 millimeter at neonate, 1 year and 2 year. Anything which is less than that, it is known as a parenchymal thinning, right? And cortex, normal 3 millimeter in infants, less than 1.5. I made a mistake too. Less than 1.5 mm cortex is associated with the renal atrophy, right? This is from the ONN, and this was published in 2020. So these are the few figures. This is something about the timing, right? If you are suspecting infravesical obstruction, you go ahead with this early sonography, otherwise wait. This is the very even interesting slide, which many of times I and Gyanendra sharing in many of these meetings, that this is not the measurement you have to take. This is the measurement. This is in the axial plane or transverse plane, anteroposterior diameter, to have a proper measurement of the dilatation. So this is very important also, right? And so not going further in detail. So here it is exactly, it is to be measured, right? And rest other things we can see into this. So again, see, this is sonography. Here there is increased cortical echogenicity. Now what happens when the child born, it is having a renal echogenicity in compared to the liver little higher. Over a time, liver echogenicity is little higher than the renal echogenicity. So any echogenicity which is higher than the liver, it is considered as a increased echogenicity. And then you can measure the cortical thickness also, right? So these are the way you can look at these cortical echogenicity, CM differentiation, and cortical thickness at the various places. Once again, here it is axial view to measure the anteroposterior diameter of the renal pelvis into the hilar area. Very important, right? And these are the way you can judge the cortical thickness at various places. If you have this kind of a sonography picture, I don't think you are going to miss anything. I have a much better series, but I could not find out that presentation which I presented into the Nair Hospital, at Nair Hospital in recently concluded pediatric section meeting, right? So very important is the transverse plane. I think Gyanendra, you are agree. This time I'm showing the axial plane.
Yeah, perfect.
Right? So here you can see the bladder, you can see fantastical, right? You can see the prostate, you can go right up to the rectum. So you can, with a very good done sonography, you can see internal echoes, you can see juxtavesical dilated ureters into the pelvic sonography, and in the transverse plane, you can see dilated ureters. So here you see everything, the bladder wall thickness, right? The criteria for thickness, all of you must be knowing, all resident. In a collapse state, it should be less than 3 millimeter. Sorry, in a more than in a collapse, it is 5 millimeter. If plus, then it is cortical. This is bladder thickening, bladder wall thickness. If it is in a distended, if it is more than 3 millimeter, it is considered as a bladder wall thickness, right? Is the definition. So if you look at in this series, again, you can see dilated ureters into the juxtavesical area, right? Into this posteriorly. There you can see entire lower ureter is dilated and then getting narrow, right? So these are all sonographies done at my places. This is not taken from any book or any kind of things, right? Here you can see this all again, cortex, medulla, corticomedullary junction, renal hilum, cortical thickness, right? Peripheral calyceal dilatation, central calyceal dilatation, pelvic dilatation, all these things. And based on these are all theoretical things, that this is how we define based on AP diameter. This is SFU, we are not going to go. This is what Gyanendra mentioned about the UTD classification, which is more holistic. It involves the ureter, bladder, and in the any antenatal period, it involves the amniotic fluid. Most important criteria, whenever I get a call from the friends that what to do about this fetus, then I say that if amniotic fluid is normal till the end of third trimester or near third trimester, you have nothing too much worry, and this child can safely deliver and can be treated later on, right? So See, this is the what difference between the UTD classification and other things. It is involving the all these things in antenatal and postnatal, and gives also the some idea about the risk category, right? Low risk category, intermediate risk category, high risk category. And based on that, you can further decide your investigations and its timeline. I'm working, and we are coming up very soon with the help of Gyanandra and some other people to have a multi-institutional study whether the UTD classification and its risk factors are really useful in clinically. There are so many papers since 2014. Couple of papers have shown the a good utility of this UTD classification, and few have failed to show it. Right? They are still on SFU classification. And the most important thing is these are the prognostic factors. Renal function less than 30 to 35%. It is by cough in 1994. AP diameter, more AP diameter, like more likely to have a strong UPJ obstruction and likely to go for a surgery. This was the very famous chart from the Dillon from Great Ormond Street. There you can see if the PUBG dilatation is more than 50 millimeter at the hilum, then the chances of going ahead for the surgery is quite almost 100%, right? So it is not the hydronephrosis, the magnitude of hydronephrosis, which is very important. And magnitude is very well judged by the sonography and well done sonography, right? And then cortical transit time, Gyanandra is there. If time permits, we'll speak for a minute. And these are the things: presence of symptoms, palpable lump, sepsis, stone formation, psoriatic kidney, bilateral hydronephrosis, differential renal function in obstructed kidney to start with, right? And on follow-up, increase in renal pelvic dilatation and less than more than 10% decline. But in my practice, I don't do more often renal scan because it involves the radiation cost. But the sonography is a good help if you do a serial sonography after the initial study, and if you have increase in dilatation with the same sonologist in the same way done, with all variables are taken care. Again, the hydration, bladder full sonography, bladder empty sonography, supine sonography, prone sonography, and you just derive the whole criteria, and based on that you can decide your follow-up and the further line of treatment and management. And something about this we have to keep in mind is the transient hydronephrosis and observational period. Right here there was initial in 7 days, and then later on at the 3 months. There you can see diuretic scan is perfectly all right, right? And it is explained by the Ullman in 2000 very well. The what is the explanation is that the GFR of this kidney is not matching with the adult GFR. So GFR increases, with that urine output increases, and compliance of the renal pelvis is very much good in infant, in a fetus, in neonates, but over a time compliance reduces. These two criteria together, increase in output, urine formation, and decrease in the renal compliance, renal pelvic compliance, can lead to the overcoming the resistance which is there at the ureter, upper ureter or the ureteropelvic junction of area. And another study was, beautiful study was from the cough in Campbell in 1994, that they decided, see what he explained before 10 days, that he was about to operate patient on one month age with the suspected UPJ obstruction, and there was some problem in the family level. They didn't turn for 3-4 months, and when they came back, he said that let us have a sonography fresh. And what they surprised to him, that was his first experience in 1990, that the hydronephrosis was significantly regressed. And with that, he started this observational protocol. To start with, he was not operating any patient, whether there is a 30% function, 35% or 40% or 45% function, without observational period. And what they derived is out of 15 patients improved even with the less than 30 DRF after the pyeloplasty. So even if you have observed for a time to a patient, you are not probably losing anything, but you are giving a fair chances of avoiding the surgery in a small kid. Now, the slide which probably I skipped initially, it was no. So till 2000 in differential diagnosis, there was no mention of transient hydronephrosis. But in 2010, there was a revised guideline, and the transient hydronephrosis gone on to the top, right? So that much of the excellent studies came during the period of 90 to 2000, say 2005, from these kind of researchers and clinicians, and that has changed the entire scenario. So you can wait with the stable clinical status, in stable morphological picture, and a stable good renal function, right? And this is about the renal dilatation of multicystic dysplastic kidney. So that's all right now, right? Thank you for listening till late.
Excellent. Dr. Takvani and Dr. Ganendra, we are very happy. This is a fourth season, but still, after listening to you, we have, and I'm sure the students, they have learned a lot. And when they will go back and listen to your talk again and again, they will be able to answer everything in theory as well as in practical. So thank you very much, and good night. Dr. Gite.
1 minute, Gaurang. I would like to congratulate Saswat. Saswat, you answered most of the things very nicely, right?
Yes.
Little bit here and
Thank you,
there in clinical history, but that's okay, right? Clinical history is like that only. But rest, otherwise, you answer very nicely limitations of almost all investigations, which is very important to know the limitations of the each and every investigations, which is done in the UPGOs like cases, right?
Yes,
And
thank you, sir.
thank you, Gaurang and the Dr. Gite, for these initiatives. This initiative is really fantastic, unparalleled, and I think you are continue legacy of some good, excellent teachers which Mumbai has seen in past. Thank you.
Thank you very much, and we are not going to leave you. So again in future we'll be
Right.
calling you.
Perfect.
Excellent, excellent discussion, excellent talk by Anil, and really enlightening discussion. I think everybody learns a bit in these discussions, and we all are really, I'm sure Anil will agree, and that the students' level of knowledge is really heartening to know that they read extensively about things which we have slowly learned over a period of time. So they are developing a good base on which they will be building up their practice and knowledge in the years to come by.
Yes.
Right. And
Yes, sir.
Gyanendra, I agree. Once again, I want to give a disclosure that I learned a lot from you, at least in the field of how to do a proper sonography in the patient, and go on improving that, go on insisting my sonologist friend that I want this kind of a picture. You should have this kind of a probe machine, and I will not allow your just reporting. If you will not be able to give these pictures, I will be sending the patient again and again. And that's how we started getting this kind of lovely pictures, which is almost, I have demonstrated this on this at multiple level, multiple conferences in the national and international level, and they all ask, give me this series of the sonography pictures, because these are the very much excellent pictures. How could you get it? It's very difficult to get it, and that's why we are doing so much of CT scan. So this is what I am requesting, that make your one of the sonologist friend ready to do some good work for the neonates, infants, and the pediatric age group patients. Try to minimize the radiation in invasive investigations. Thank you.
Anil, thank you for your kind words, but I have to confess that I don't do sonography at all. It's my wife who does that, and I take her help, and I keep on
You are having a
about
privilege
these
there.
things. Yeah.
Okay. Thank you all. And next time
Thank you, sir, for joining.
Thank
Yes.
you. Thank you. Venkat.
Thank you, Gite sir. Thank you, Gaurav sir. Good night, everybody.
Good
Chalo,
night.
good night.
Good night. Good night.